Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vera Therapeutics.
Hello and welcome to this Medscape education event called Filling the Gaps regarding new data and insights on emerging therapies for IgA nephropathy. I'm Rich Lafayette. I'm a professor of medicine and nephrology at Stanford University, and I'm really honored to be joined by Dr. Brad Rovin. Brad, why don't you say hi and introduce yourself?
Thanks, Rich. I am a professor of medicine and pathology at Ohio State University in Columbus, Ohio, and it's my pleasure to be here.
So today we'll review the current guidelines for the management of IgA nephropathy, briefly review IgA nephropathy pathophysiology and the basis of B-cell targeted therapies, look at most recent data for B-cell agents for IgA nephropathy just presented at the ASN Kidney Week in Houston. So we're going to be starting out reviewing the new KDIGO guidelines, which have been merging over this last year and were formalized recently. First, in terms of treatment targets, it's really important that the targets are now to try to achieve and maintain proteinuria as low as you can go. You want to get the proteinuria less than 500 milligrams per day, and ideally to normal values of less than 300 milligrams per day. At the same time, you want to achieve stability in kidney function such that there's kidney function loss no different than healthy people. And that suggests, again, less than 1 mil per minute loss per year. To achieve this, the KDIGO guidelines suggest that we identify patients at risk of progressive kidney function early, that we biopsy people who have more than half a gram of proteinuria and a possible diagnosis of IgA nephropathy. And once we find that they are at risk through persistent proteinuria or through the IgA risk prediction score, then it's important to both manage the IgA nephropathy specific drivers for nephron loss, and if they have chronic kidney disease and ongoing proteinuria, which most do, to manage those generic responses to IgA nephropathy-induced nephron loss. For the specific intervention, that would be looking to reduce the pathogenic forms of IgA and IgA immune complex formation itself. So far with approved agents, we really have targeted release budesonide and systemic steroids to do that. We also want to reduce the downstream effects of the immune complex, which could be achieved also with targeted release budesonide or systemic glucocorticoids. And with iptacopan now released after the guidelines, that may be another approach. For the more generic response, we want to assure, again, that the blood pressure is well controlled, that we do lifestyle modification, but we want to reduce glomerular hyperfiltration and the impact of proteinuria. And we want to make sure that patients are at low cardiovascular risk. And that's, again, achieved through lifestyle modification, best diet, exercise, avoidance of smoking, maximizing RAS inhibitors, considering adding SGLT2 inhibitors, or using endothelin blockade with either dual endothelin blockade and angiotensin receptor blockade, such as sparsentan. And again, after the guidelines, there's now an option perhaps to use atrasentan as well. And then in specific populations, there may be roles for other immunosuppressive drugs or other opportunities, but this is really where we are in 2025, sorting out these guidelines and figuring out the best way to get to our targets. So let me bring it back to the architect of those guidelines, or contributor at least. Are there still gaps in the guidelines, and what might we have done to address the guidelines and fill in some of the missing issues?
Yeah, thanks, Rich. So I think one thing is that this scheme that you just went over is really modular, and I really like it. And I know a lot of people, there was a lot of feedback about this scheme, and we went back and forth. But the reason I like it is because as new drugs become available, just like you've shown in a different color, you can slide the new drugs under a category in which they belong. And that's not to say that the drugs all have one effect and they don't have any other effects because, as you well know, there's multiple effects of every drug, but the majority of what they do can be sorted out that way. So I like that schema for that reason. I think one of the things that we have to do in the field, which is, as you well know, exploding, is now that we have drugs and we have drugs with different mechanisms of action, and we realize that IgA is not a benign disease and we need to treat it, and a lot of people will progress to end stage kidney disease if not treated, is to figure out who needs what drug. And I think the biggest problem in IgA right now, today, as we sit here, is there's really no good biomarkers to tell us what to use. And a good example might be this whole issue of immune deposits in the kidney and how inflammatory the kidney is in IgA. IgA is not a traditional, really inflammatory disease like you see in lupus or ankylosing. Nonetheless, we believe, and certainly the data suggests, that there is ongoing inflammation in the kidney. How do you rank that inflammation? Do you need, for a particular patient, a complement inhibitor to hit that inflammation? Is their disease mediated by complement, or is a different person have a different disease mechanism causing injury? And so I think this is where the guidelines are going to go once we have the investigators in the field, all of us included, finding out these biomarkers and finishing up the pathophysiology of IgA nephropathy. We'll talk about the four hit hypothesis in just a minute, but that's a skeleton outline. So I do think that there is room for modification. We're going to talk about some of the newer drugs that you and I saw at the ASN. And of course, these will be focused on B cell therapies, and they will slide very nicely under the module of, we think, of changing the formation of pathogenic IgA and the immune complexes.
That's sounds great. I will, as you said, turn it over to you because I think to really understand our way forward, it's always driven by understanding the pathogenesis. So why don't you go ahead and review that for the next few minutes, and then we can come back to how we address it with new treatments.
Yeah. As of today, we all ascribe to what's called the four-hit hypothesis of IgA nephropathy. And just very simply, this is outlined in the slide you see here. We have, for whatever reason, an increase in circulating galactose deficient IgA. Now, all of us make galactose deficient IgA. I've measured it in myself for some of my lab studies, and I am a big producer, but I don't think I have IgA nephropathy. And so something else has to be involved with galactose deficient IgA. And what we hypothesize is that under the appropriate genetic predisposition, we can make autoantibodies, and they can be IgG or IgA autoantibodies. And as galactose deficient IgA can glom up itself and make big aggregates. And these tend to deposit in the mesangium of the kidney. Once that happens, so that's hit one, which is the excess galactose deficient IgA. Hit two is the other thing that forms the immune complexes or immune aggregates. And it's very convenient. I come from an autoimmunity background, so I like to think about autoantibodies. I know there's some controversy with that, but it makes it very simple in my head, straightforward. The immune aggregates then form. That's hit number three. And hit number four is they wind up in the kidney, and winding up in the kidney in the mesangium, they trigger a whole bunch of responses that are basically untoward for the kidney. Complement activation, chemokine and cytokine release, and they also induce mesangial proliferation, fibrosis, and eventually interstitial fibrosis, which of course we don't know how to reverse right now, leading to chronic damage of the kidney. So that really, in a nutshell, is the four-hit hypothesis. Now, I think over time, that's going to be modified with much more information. I think one of the things that people are proposing is there a hit zero? Why do certain people have so much galactose deficient IgA coming across? We think it's from the mucosa, primarily maybe from the gut, maybe the respiratory mucosa as well. So I think these are really reasonable questions to ask. So, when we're thinking about the pathophysiology of IgA nephropathy, one of the things that has come up is if we have antibodies being formed and we have maybe autoantibodies or at least other antibodies causing aggregation or immune complexes, what would happen if we targeted the B cells? And just for everyone to know, Rich and I and several others worked a long time ago on a paper or a study looking at the anti-CD20 B cell drug rituximab in IgA nephropathy. We were sure we had a winner. We said we're going to make the B cells go away, and this is going to really help IgA nephropathy. And of course, what we found was it didn't do anything, which was remarkable at the time, but that's where we were. And so some brave souls in pharma said, what about if we move away from depleting B cells and rather look at B cell modulation? And I think this is where I want to bring us so we can have a robust discussion of what we saw at the ASN. Because if you hadn't been to the ASN, it was a very exciting, it could have been the IgA ASN meeting because there were lots of really good presentations on IgA. But if you look now at the B cell survival factors, and this is where the field is really moving, B cell survival factors called BAFF and APRIL are really important for a lot of functions that maintain and allow the B cells to mature and actually push the B cells towards the development of plasma cells. And they work through several different receptors and they work through overlapping receptors. But BAFF or BLIS, B cell activating factor, works through the BAFF receptor, the BCMA receptor, which is often found on plasma cells and plasmablasts, and the TACI receptor. APRIL doesn't hit the BAFF receptor, but it also hits the BCMA receptor and the TACI receptor. And these things normally have a little bit different function. So, in general, these B cell survival factors increase B cell longevity. They stimulate B cell proliferation. They stimulate IgG class switching. They can enhance the antigen presenting function of the B cells and germinal center formation. And they also have a role in B cell tolerance. So, what's more important for us right now is what are the consequences of inhibition? And I'm going to give you the consequences of BAFF and then APRIL inhibition because we have drugs that we're going to talk about that target both or target one. So BAFF inhibition impairs B cell maturation. It decreases then the number of mature B cells. It decreases total IgG production or total Ig production, immunoglobulin production, including IgG. And it decreases T cell dependent and independent responses of B cells. When we look at APRIL inhibition, and this is really intriguing, APRIL is involved in a lot of stuff that really makes sense for IgA. You have intact B cell maturation if you just get rid of APRIL. You have a relatively selective reduction of IgA. So right away, we have a very appealing sort of mechanism for IgA nephropathy. We can still have intact immune responses to vaccines, and you get partial IgG and IgM depletion. So each one has a little bit of its own action. But in general, and I'm going to throw this out there, happy to hear what you think, Rich. One of the things we miss when we just do anti-CD20 therapy, so rituximab, is we're not touching the plasma cells or plasmablasts at all. And maybe some of the effects we're seeing here really have to do with how these cells move towards becoming antibody producing cells. And I wonder if that was partially one of the reasons we did not see a successful trial with CD20, anti-CD20. Three of these, atacicept and telitacicept, were discussed in depth at the sort of late-breaking, high-impact trial sessions. And then we have the APRIL inhibitors, sibeprenlimab and zigakibart, They're very difficult. And then the anti-CD38 agents, felzartamab and megazitamab. And I'm sorry, I have a lot of trouble pronouncing these. Okay.
All right, let's move on and see what these agents are doing. We already have good background from earlier studies suggesting BAFF/APRIL inhibitors can be highly effective in IgA nephropathy, and some of the data is looking really good. And at ASN, it was really great to present the preliminary phase 3 data for atacicept on the next slide, where we were able to look at the interim analysis. And here you can see that for the phase 3 trial of atacicept in IgA nephropathy, over 400 patients were randomized. Ultimately, 428 received atacicept for placebo. They were well balanced in terms of distribution. And in this interim analysis, when 106 patients in the atacicept group and 97 in the placebo group reached 9 months, that was our goal, to look at the data, to look at the primary outcome of proteinuria reduction. During those 36 weeks, there was 7 withdrawn from the atacicept group, 13 who stopped placebo. So pretty good numbers of patients who were stable to look further at their data. And then on the next slide, you'll see that this is a pretty representative IgA nephropathy population, around 40 years of age, a slight male predominance, a good racial ethnic balance between Asian and non-Asian patients, with some representations of Hispanics as well. And then again, baseline hematuria was there in the majority of patients. Proteinuria was pretty severe at a protein to creatinine ratio around 1.7, 1.8 grams per day, showing that more than the average protein excretion was more than 2 grams per day. And patients had reduced GFR in the mid 60 mils per minute. They had significant IgA levels, slightly above normal. And what you can also see is that the majority of patients, they were allowed to be on SGLT2 inhibitors together with their maximal tolerated RAS inhibitor for at least 3 months, and more than 50% of the patients were actually on SGLT2 inhibitors, and the patients were only a couple of years from their biopsy. On the next slide, you can see that the study met its primary goal. There was a very substantial reduction of proteinuria from baseline of about 46%, which is, again, statistically and clinically relevant. When you look at it compared to the change in placebo, that was about 7%. The net change is 42%. Again, very important. And on the next slide, you can see that was achieved with about a 2/3 reduction in the galactose-deficient IgA1, as some evidence that the immune complexes are likely reduced. Next slide. You can see that hematuria was substantially reduced at 80% of patients who had it at baseline, had resolution by week 36. And finally, across subgroups, this seemed to work in everybody, whether they're older, younger, male or female, from Asia or not, white or non-white, higher or lower proteinuria, higher or lower GFR, and importantly, whether or not they're on SGLT2 inhibitors, patients are still enjoying that 40 to 50% reduction in proteinuria. And importantly, this is really well tolerated. So despite blocking BAFF and APRIL, the events in the atacicept group pretty much look the same in the placebo group. Again, there's actually less severe adverse events. The infection rates are very similar. The severe adverse event related to infection is actually numerically a little bit lower, but similar. And the main difference is there was some increased injection site reactions with the active drug. But overall, this really looks very nice that the drug was highly effective at reducing proteinuria, hematuria, and galactose-deficient IgA, as well as being well tolerated. Brad, I'll give it back to you to talk about the povetacicept results.
Thanks, Rich. But before we do that, let's spend a little bit of time on this study. You presented this study and it had a simultaneous publication in the New England Journal. I think there's some things that are profoundly important here. The first thing that really caught my eye is the uptick in use of the SGLT2 inhibitors. Not that we're not using SGLT2s, but you made this comment, and I think this is really important. In the face of SGLT2 inhibition, these drugs are still providing benefit.
Yeah, and again, I think it makes sense again, and it supports the KDIGO guidelines as well. That in that effort to get to goal of really low proteinuria, getting it towards normal, there's a bunch of different avenues that are leading to proteinuria, and some of them are hemodynamic and physiologic responses to lost nephron mass. The RAS inhibitors, SGLT2 inhibitors do a great job there, but there's still contributions from those things that modifying B cells accomplish, which again, hopefully does mean that reducing immune complex, reducing resulting inflammation, complement activation are all showing up in that proteinuria and hematuria, and that you really are the sum of your actions and that there's not one that's just as good as the many.
And I think that's really well put. Now, I'm going to push you a little bit. And I know that you didn't present this because we're not allowed to present and we don't know the GFR data. But you were involved in a preceding publication looking at the GFR data over time with etacicept. And I think that's worth a mention just a little bit. Again, with the caveats that was phase two, and we're going to look at that for phase three, et cetera. But the data were so impressive, I think it does deserve a mention.
Yeah, I think that's why there's really so much excitement. It's not just the proteinuria reduction, but in phase 2B for atacicept with 96 weeks of follow-up, again, GFR progression in a very high-risk patient group was really down to that less than 1 mil per minute per year. And all the other markers at 9 months now look very similar, if not slightly better than the phase 2 study. And as you're going to talk about povetacicept, and we saw about telitacicept, those also reduced GFR progression down to normal levels and no progression of GFR loss. So it's really spectacularly appetizing. We want to see those results, obviously, before we really celebrate in phase three, but that looks like a strong predictor that we're really going to see GFR preservation better than we've seen on net effects of targeted steroids and hemodynamic interventions so far. So I think that's why everyone's so optimistic.
Yeah, absolutely. I use the word excited. I haven't seen studies like this very often in any kidney disease. Now let's just jump forward into APRIL only inhibitor, and that's sibeprenlimab. And Prolumab, the study design is shown in this slide. It's the same as all of the other study designs. We choose Sibi versus placebo. Everybody has a background of RAS inhibition. This study also included a lot of patients, about 50%, that had SGLT2 inhibitors on board. And then the data are presented over a 9-month period of time looking for a decline in proteinuria. And then over 2 years, we'll look at the GFR slope, just like all the other IgA trials. And the population is given on this slide. It's not different really than the other populations. I think we're doing a really good job at getting very standard populations into the IgA trials with a good mix. Again, about a 50% reduction in proteinuria in the sibeprenlimab group versus the patients who were in the placebo group that had a slight increase, but pretty much stable proteinuria. And then you can see that the proteinuria starts to decline in all of these B cell modulating drugs fairly quickly, remarkably quickly, in my opinion. But here are the data from the UPCR over time, and you can see how impressive that decline is. And then if you look at the forest plot for subgroup analysis, just like Rich showed you for etacicept, we saw benefit in all of the subgroups of patients throughout the different cuts in this trial. Again, suggesting that these drugs are having an important effect on everyone with IgA nephropathy. And then if we look at these are some additions of the forest plot. It didn't matter if the patients had a high degree of proteinuria above 2 grams or below 2 grams, or high GFR or very impaired GFR. We still saw benefit from the APRIL inhibitor. And just the atacicept galactose deficient IgA1 declines substantially. As Rich pointed out, about 2/3 of this measured level goes down in the circulation. APRIL levels go down as expected. This is an anti-APRIL antibody. And the adverse events, I don't want to go into specific adverse events, but the drugs are very well tolerated. And the adverse event profile is very similar between placebo and the sibeprenlimab group. So this is all suggesting, confirming that this pathway of B cell modulation really is quite impressive in IgA nephropathy.
So, Brad, also at the ASN was really exciting to see that there's some data presented for other APRIL blockers and for zigakibart. We now have 2-year data also showing really beautiful control of proteinuria in phase 2, GFR control, proteinuria control, and control of that galactose deficient IgA. So again, APRIL inhibitors, generally, APRIL BAFF, just B cell modulation's just looking wonderful. It's very exciting indeed. And then again, the other excitement is that we use these B cell modifiers as a way to control immune response and plasma cells, but we have direct antibodies against CD38, against plasma cells as well. And there was data presented as well in small numbers of patients for felzartamab and mezagitamab, both anti-CD38 antibodies. And again, the early days are again looking really promising with reduction in galactose deficient IgA, reduction of proteinuria, stabilization of GFR, and tantalizingly off-drug effects that suggest that these can actually last for a while. Again, very early follow-up, up to 18 months, though, off drug. And again, looking like there could be differences in deeply depleting plasma cells directly, but more to see in follow-up data.
But I want to push you a little bit. The at least the felzartamab data that I looked at, you stop the drug. As you said, proteinuria stays stable for a really long time, which is actually not what we see with any of the other drugs so far. But that's in the face of galactose deficient IgA returning. So what does that tell us? Does that push a little bit on the four-hit hypothesis?
Yeah, I think for sure it might. And it may be that the response to that galactose deficient IgA1 is the important part, or the mobilization of it with complement or other factors to the kidney are the important part. Because just like you mentioned, people like you may run around just with high galactose deficient IgA1 and be fine. So we will see. I think right now we just celebrate that B cell modulators are looking great and will be approved by the FDA shortly and hopefully globally available soon. That the early data and plasma cell agents look great, but getting into those maybe weeds, but really important weeds of who's the perfect patient, are there biomarkers to predict it, how do patients do off the drug when they need to stop it, or if we want to try stopping it. Lots of issues still need to be worked out, but luckily there's treatments available. We can really work towards getting to the goals we have for our patients to control their proteinuria, control their GFR decline in increasingly safe ways. So I'm excited. What do you think?
I think the same way. I think that these drugs, as they're working, we are going to learn so much about the pathogenesis of IgA nephropathy. And really, our knowledge is expanding just with these clinical trials, even at the genesis of the disease, not just the treatment of the disease. So let's sum up. Unfortunately, we have to go. I think Rich and I could talk about this all day, as often do at meetings. But I think the audience should appreciate now that there's a large number of agents in development for IgA nephropathy, besides the ones that have already been approved by regulatory. They're attacking different parts of the presumptive pathogenic pathway. They may be showing us new ways to think about the pathogenesis of IgA nephropathy. As Rich and I hopefully have detailed with you, combination therapies might be quite appropriate. We certainly want to think about targeting the immunologic basis of the disease. And unfortunately, we often get patients that have chronic kidney damage already. So we want to stabilize the chronic kidney damage. We really do want to emphasize that the detection and early treatment of IgA is really key to the safe and effective management of this disease and preservation of kidney function for these are mostly young people who have IgA nephropathy. They have a very long time horizon. So we want to do this early. And I think we have to start educating all of our colleagues about this because these are complicated pathways. And these are things that we have not thought about very often as nephrologists. So brand new information for us, very exciting. And listen to everyone and Rich, always a pleasure discussing with you. Thank you all for listening to this and participating in this activity. And then on the right side of this page, you'll find some useful tools.
Thanks, everybody.